Okay, well, welcome everyone to the speaker series of the Center for Health Informatics. Our center is here to support research being done at the Cummings School of Medicine, both through collaborations and supporting data facilitation and analytics. We have speakers who are renowned in their work in order to share their experience and foster more collaborations and possibly make data more usable for other kinds of studies and other types of research, which we'll hear about a wonderful data set today. Our speakers are three speakers today. I'll first introduce Dr. Suzanne Tuff. She's a professor in the Departments of Pediatrics and Community Health Sciences in the Cummings School of Medicine at the University of Calgary and faculty of the Max Bell Policy Institute. She's a member of the AwareCo Center and Alberta Children's Hospital Research Institute. She has multiple designations as in the Academy of Sciences and other awards that she's received. And please do look at her bio on the University of Calgary, as it is quite extensive. Today, her role is the principal investigator of the All Our Families study. And with her, she's brought Dr. Sheila McDonald, who is also co-investigator for the All Our Families cohort and a research scientist in maternal child health in the Department of Research and Innovation at the Alberta Health Services. She's also an adjunct professor in the Cummings School of Medicine and has methodological skills in research methods, complex data sets, and longitudinal analyses, and content expertise in maternal child health, birth outcomes, and child development. So they've also brought their a colleague today, postdoc, that I'll let them introduce as the study discussion progresses. So please proceed, and we'll, if you have questions, you can put them in the chat, I believe, but we will just open up for discussion after their presentation. Thank you.
Thank you very much, Catherine, for the invitation to present today and to kind of frame the work that we've been doing, hopefully with an interest on the methods that we've used in our cohort over time, and then some of the strategies that we've also applied to retain and engage our participants and to share what we're learning with community. And Sheila and I have worked together for a long time, so since I'm going to be in control of the slides while she's talking, we'll see how well we really know each other. So here we go.
Here we go.
So I'm just delighted to talk about the All Our Families study, a longitudinal community-based cohort that we started in 2008. And we're going to talk today a little bit about what the cohort is, the kind of data that we've collected. As I mentioned earlier, how we've retained participants, how we're optimizing the use of this data, hopefully to the benefit of many people on the call here today or colleagues that you know. We'll have an example of how we've used the data. And one of the key things that Tona will bring to the table, our PhD student, is a strategy for weighting some of the data, which is an important component of using longitudinal life course material. So what is All Our Families? It's a longitudinal cohort that, as I mentioned, began in 2008. We follow approximately 3,000 youth, but initially mother-infant pairs. And as they approach adolescence, now 15 and age 17, we essentially have created two cohorts because the youth are participating by way of answering their own questionnaires and contributing their own data to the cohort. The overarching theme of All Our Families has been to understand the intersection between the early life environment, later health and well-being, as well as to understand contemporary issues that are influencing the well-being of families and children. You can imagine the flood, we had the COVID pandemic, and we've had a number of unexpected events, and having the cohort has enabled us to understand some of these critical moments with good data. So, as I mentioned, over 3,000 families, most of them are educated and married. 75% of the women are employed. 40% earn less than the median income of $125,000 a year. 20% are non-white, and 12% are food insecure. And one of the comments that I'll make now and probably again is one of the key things when you're looking at longitudinal population-based data is to really understand the characteristics of those who are retained or engaged in the cohort, to understand for whom your findings or analysis are generalizable. And we're really thrilled that the cohort represents, by and large, the majority of families parenting children and youth in Calgary. And in particular, I'll draw your attention to the median income. So when you're looking at who these results reflect, there can be some reassurance that in words that I use as a population health scientist, that our data looks like most people most of the time. And I'll say a bit more about that. So when we compare the demographics of the cohort on this slide here, you will see those in the All Our Families cohort are slightly more advantaged, but not substantially more advantaged. And this reflects often the qualities of those who choose to engage in research writ large. And to my point about most people most of the time, we often say when we're making this data available that if you are looking at a subset of highly vulnerable or unique populations, this may or may not meet the needs of your research question, because we have different research methods for different research questions. And so we are particularly interested in policy, public health, community-based well-being, and findings that can be generalized to families raising children in an urban setting today. And so with that, I will pass it on to Sheila.
Thanks, Suzanne. And I'll just preface this by saying after each slide, I'll be like, next slide. So just bear with me, but here we are. Okay, thanks. I'll talk to the methods. So yes, we're on the right slide. I'll speak to recruitment, data collection, data linkages, survey development, and stakeholder engagement. And we had a project that really engaged the youth. And as Suzanne was noting, we are now, the children are now youth. They're 15 to 17 years of age. So we're engaging them more and more over time. And there's some different methodology that goes with that. So next slide. So yeah, when we started in 2008, which is quite a while ago. Anyways, we had a three-pronged recruitment strategy, and recruitment it spanned 3 years. So we recruited participants in the community using posters and word of mouth. We recruited at low and high risk maternity clinics, and we also had a partnership with the former Calgary Lab Services. So as you can see on the slide, the data collected does cover a number of domains and constructs, and really they were relevant to the time period. So we're collecting prenatal health data during pregnancy, we're collecting child development during post-birth and onwards, and we also aim to cover the same construct over time. So we use scales with adequate psychometric properties, excuse me, widely used scales in research and some that are used in clinical practice. For example, on child development, mental health, maternal mental health, etc. So some examples would be the Ages and Stages questionnaire, the BASC, which is the Behavioral Assessment Symptom Checklist, the EBDS, which is the Edinburgh Postpartum Depression Scale. We also have the CESD Depression Scale. So these are widely used research scales. Social support, the MOS scale, which is the Medical Outcomes Study Social Support Scale. So we tried to use validated and standardized scales as much as possible. Otherwise, we had item-developed questions based on stakeholder input. And the most recent data wave actually measured interesting constructs such as flourishing, eco-anxiety, constructs not seen on this slide, but just to say we do keep up to date with contemporary issues and how to best measure them in our study. Finally, we linked to, not yet, Suzanne, hold on. Back to the slide. Yeah, it's all good. We linked also to labor and delivery records at birth. We asked for consent for this at recruitment. So during pregnancy, all our family mothers were asked to consent to linking to medical records using their PHNs. And about 90% provided written consent for this. And this was very specific to APHP. So that's the Alberta Perinatal Health Program for labor and delivery records, which I don't think APHP is still in existence, but nonetheless, we linked to that data set after birth. And we also collected blood samples twice during pregnancy and cord blood at birth, and more on both of these in the next couple of slides. Next slide, please. So as mentioned, we linked to labor and delivery medical records at birth with consent given during recruitment. And we've also had some additional linkages since then. We've linked AOF survey data with administrative data repositories, including outpatient data, inpatient data, emergency department data, physician claims, public health data, PIN data, which is pharmaceutical data. And these are repositories held in both Alberta Health and Alberta Health Services. So an example here on the slide shows one project we were involved in. We were able to link to child records. So we linked AOF children to their health records via maternal PHN and unique linkage identifier, so the ULI, and of course with ethical approval. And so as you can see in the flow diagram, this was via vital stats. And this project actually was looking at the prevalence of child mental health disorders in admin data and comparing that to survey data. So why do we link to admin data? Well, we can examine diagnoses, frequency of healthcare visits for a certain diagnostic code, length of stays, and for PIN data, we can look at drugs dispensed per years, and we can do some economic analyses as well, so treatment costs. So in summary, data linkage has been performed for both maternal and child outcomes in admin data beyond the perinatal period, up to age 8, and also in older ages, we're pursuing that. So we obtained a waiver of consent for this. So we did not reconsent the full cohort, but we achieved a waiver of consent achieved. We were approved for a waiver of consent from ethics. And when we consented at recruitment, that was only for that particular linkage. So we do require consent for these additional linkages. And usually it is a waiver of consent. And also that comes with this is data sharing agreements with Alberta Health and Alberta Health Services. So we follow the appropriate processes. Next slide, please. In terms of additional linkage, so we've also combined our data with other Canadian birth cohorts. And this does really help with increasing sample size and generalizability to answer some important research questions. So just two examples here. One on prenatal alcohol exposure. So this was a combination of 5 cohorts, two from Alberta, AOF and APRN, one from Hamilton, the family cohort, one from Ontario, one from Montreal and Quebec City and Sherbrooke, that's the 3D cohort. And this allowed for a total sample size of 11,448 participants. And another linkage was with the urban environment. So that's on the bottom of the slide here. This was 3 Canadian population-based birth cohorts. Again, it's the Quebec one, the 3D cohort, all our families here, and the child study, which is across Canada. And this resulted in 9,000 mother-child pairs. So it's combining that data. So we link ourselves to administrative data, but we also are involved in some of these consortiums where we're combining data and able to answer these research questions for more generalizability and bigger sample size. And in terms of the urban environment, it's a bit of a double linkage here. So we're not only linking or combining with other cohorts, but we're linking to the CANU data, which stands for the Canadian Urban Environmental Health Research Consortium. And this linkage is by participant postal code for information on environmental exposures, such as, and also, environmental risk factors or protective factors. So building density, community facilities, walkability, street connectivity, greenness, pollution, etc. So this one study was all around environmental exposures during pregnancy. And Tona, who's here today, is using the CANU data in his research. And if any questions come up, we're glad Tony is here to answer those. So thanks for that. So next slide. So as mentioned, we also collected blood samples from our participants twice during pregnancy and cord blood at birth. And this was from approximately half of the sample, half of the cohort. So about 1,800 participants who were part of the predicting preterm birth component of our study. So we have time 1 and time 2, and the time 1 and time 2 aligns with the second trimester and the third trimester of pregnancy. So we have plasma and serum samples. And to date, these have been used for cytokine, metabolomic, and metalomic profiling. And so that's the study on the left-hand side below. We've also isolated DNA, and this is available to address research questions. So our biocore team can answer more detailed questions. I'm not sure if they're here today about the availability of samples for research, and that would be Dr. Donna Slater and Dr. Katie Chaput. And the sample data, the biological sample data, can be linked to the survey data. So that provides rich information to answer research questions that require both biological and survey data. Next slide, please. So this is more on survey development. So All Our Families does have a track record of collaborating with experts, clinicians, and community groups to really understand research needs and policy questions, as noted by Suzanne earlier. So survey development takes about a year, and a year prior for a given data wave. So we consult with key stakeholders, we identify priorities, we develop the questionnaires, including pilot testing, and then we get it into REDCap. Our surveys are all online now. They weren't always online. So back in the day, back in 2008, we were mailing out paper surveys, and then we would scan them into Teleform, which was a platform to allow for that, which would then convert the information into an Access database. But we're now all online. Recently, or in recent data waves, we were still giving the option of paper surveys, but I would say 100% are online now. But we do offer that option if required. And in our most recent data wave, we've collected data from the children themselves. So I'll talk about that in the next couple slides. So next slide, Suzanne. This was a small project or a small grant project that we had where we consulted with youth and other stakeholders to develop the youth survey, as we wanted to collect data from the youth themselves. So before this time point, all data on children were maternal report. So receiving data from the youth themselves or the children themselves is a really important achievement in our study and aligns with how the cohort is growing. So next slide. So this project really was around consulting with stakeholders, including youth, for developing our youth survey. So the youth at this time point were around 12 to 14 years age. So the goal was to consult with community, clinical, and government stakeholders on priority topics and questionnaire content to inform this survey. So we had 16 members of community-based organizations. You see some of them on the slide here. We had clinicians, we consulted with academics, and we also consulted with youth. So this was our approach. This is our approach for developing surveys over time, but this was a really important one because we're really wanting to prioritize those topics and questions that were important to youth. So next slide, Suzanne. So what we heard when we consulted with these different stakeholder groups, this slide talks about what we heard from community groups and experts. Well, we heard that access to mental health services at this age is needed to inform policy and policymakers and clinicians about unmet need. We heard that screen time and physical activity are very important topics. So we knew that, but it's also hearing from our stakeholders really bolsters the interest in addressing these topics. But they're hard to measure. So we really had to sit down and figure out how best to measure these topics. We also heard from our community groups and experts that family functioning is an important concept for understanding youth behavior. And we also heard that parents will not be able to report accurately on certain teen behavior. We knew this, but again, hearing from our stakeholder groups just really addressed this need for collecting data from youth themselves. So what we heard from teens and the youth themselves would be the next slide. And here our goal was really to engage adolescents to determine what is important, what are those priority topics, and what are their preferences for questionnaire delivery, and what incentivizes them to participate. So we approached the Child and Youth Advisory Council, and they are made up of 25 to 30 members, ages 12 to 21. And they live in urban or rural areas across southern Alberta, coming from diverse cultural backgrounds with varied life or health experiences. And this advisory council commenced in the fall of 2003. So they exist to this day and have been up and running, and they're under the leadership of the Alberta Children's Hospital within the Family and Community Resource Centre. So we approached youth from this group to help develop our survey. And what we heard, next slide, Suzanne, and you might have to press the button a few times. So we heard that what's important is fitting in, memes, sports. Again, we could guess that would be important topics, but hearing from the youth themselves just really addressed what we should be asking. So next slide, Suzanne. So what we heard from the teens themselves or the youth themselves, youth want to answer questions on their own. Parents should not be able to see their answers. Privacy is very important to youth, especially online. Sensitive topics from youth we heard were around puberty, changes in their body, body image, bullying, peer pressure, social media, relationships, risky behaviors, race and religion, and identity. These are all sensitive topics according to youth themselves as well. So how to best ask, and will youth be honest? So we asked them this. In terms of honesty, they told us this, youth are more likely to give honest and responsibly answer, taking the question very seriously, if they are guaranteed anonymity. So if their participation is anonymous. And how to best ask? Well, phrasing matters, and it does depend on how one presents the topic or phrases the question. And it's really important to get youth interested in participation. So incentives are helpful for that. And we do give incentives for mothers and youth during our data collection. And we talked about open-ended questions, a number of questions. So less is more. So be very focused in what we're asking. And ask them about things that might be important. So we have some filler questions as well, just to increase engagement. What would you like to do when you grow up? What's the ideal situation that you can imagine yourself in? And so some of these questions that really engage them in addition to asking these important topics as well. Privacy is important. Confidentiality is important. And we did get consent from mothers to ask youth directly questions. And so it's called youth assent when we get assent from youth, but we did have to get maternal consent to get youth assent. And as we move forward with the cohort, around age 15, 16 is when we probably can ask directly the youth for their consent to answer questions and not have to get maternal consent previous to that. So I'll talk a few more slides on retention approaches, and then I'll turn it over to Tona. So we can go to the next slide, Suzanne. So perfect. This is a flow chart from our methods paper, which you can see here that we started with around 3,000 mothers. And as you go down in the flow chart, you can see the response rate for where we're at in our questionnaire now. And our response rate has been quite good, averaging around 70%, 75%. And the eligible population determines our response rate. So even though we started with 3,000, the eligible population for a given data wave did fluctuate over time, depending on, well, for those postpartum or postnatal time points, it was around, the appropriate age for some of those developmental questionnaires that we sent out. So our sample size did decrease because we might have been a bit late getting ethics or funding or whatnot. So we really had the appropriate sample size for that given data wave. And then as we moved forward into age 5, age 8, all those who remained in the cohort were eligible to respond to the survey. And we have maintained high response rates over time, as you can see from the flow chart. So next slide, I'll talk a bit about how we retain engagement. So we use incentives, like I mentioned before, so gift certificates for questionnaire completion. We have annual newsletters or biannual newsletters around our findings. We recognize staff. We do did you know sorts of things, and the newsletters are quite engaging. So we keep our participants in mind as we develop those newsletters. We have occasional prize draws. for our participants. We are on social media. We have a website as well, All Our Families website. Check it out. I think it's probably at the end of the slide deck here. We answer questions. Participants do contact us, and we are thoughtful in our response to their questions, and we do get back to them. And we do give a gift, an incentive, regardless of survey return. And this is far and few between, but it really is something that we are engaging our participants, and we're not questioning why they're participating, because we really are responsive to and recognizing that they're participating. And that really is what it's about. It's not to really incentivize in the wrong reason. It's really to recognize their participation. And we're really grateful for their data, and we use it very responsibly. And later on, Suzanne will be talking about the workbook, and that's another engagement strategy with our participants and giving back to our participants. So with that, I will turn it over to Tona, and then I'll come back after Tona. Over to you, Tona. You're on mute. Okay, there you go.
Yeah. Okay, cool. Thanks. Okay, so I'm going to talk about attrition rates. So despite our best efforts to retain individuals, we still have a tough time keeping everybody. So we expect that some people are going to just not respond to surveys over time, and we expect that we're going to lose some people over time as well. Sorry. Okay, so when we lose people over time, the fear is that as those people leave, that this is, they're not leaving randomly, and so it may introduce bias. So is the group that we have at 14 years now, after the start of the survey, is that different from the group that we started with? And if so, is that going to start biasing some of the estimates that we're trying to look at? So the goal is to use some sort of like weighting, so that we can account for that over time and weight the current population or the current sample back to the original sample. So there's a few steps to that. The first is to create a model that's going to predict continuation in the study. So we took a couple of approaches to that. We made one on our own, what we thought was going to predict dropout over time. And we also used lasso regression, so a variable selection technique, to help us pick the most relevant variables. And from that, we're going to evaluate it like any prediction model. So we're going to look at the discrimination and the calibration of those models, and then look at how the weights actually balance our current sample characteristics. So I won't go through the whole prediction model stuff, but we had good discrimination, and the calibration was good actually for both models. But the model that used this data-driven approach, the lasso approach, it did seem to do better in terms of actually balancing our characteristics. So I'll show you how we actually look at that performance. So we use standardized differences to compare. And so you'll see the triangles on the right side. That's looking at the baseline. So how different is our group that continued on in the study from people who actually dropped out of the study over time. And so you see some big differences where we expect that the people who continue on, they tend to be higher income, they tend to be more educated, they tend to have less mental health symptoms, and they tend to be, higher proportion is Caucasian. But the circles on the left is actually when we apply those weights, and then we check the standardized differences again. What you see is that the difference goes down quite a bit. And so we think that our weights are working pretty well. The next step then is to look at over a few different waves. So right now I'm showing you at 3 waves, at 3 year. But if we look at the 3 year, the 5 year, the 8 year, and then our COVID pandemic survey, which is about 12 years, we see that applying those weights also reduces the difference between the continuers and the non-continuers in the same fashion. So good that we can apply them across waves. So I guess the bottom line would be if somebody's looking to use our sample and are concerned about attrition over time, we have these weights at each sample that you could use to try and account for attrition. And so an applied example is here. Kind of how we started with this is we had a project where we were looking at depression symptoms in moms. starting at the 3-year survey, 5-year, and 8-year, but we wanted to know how the COVID-19 pandemic affected it. And so one of the reviewer comments that we got was to actually employ these weights. And so that's kind of where we started working on this to weight our sample using these attrition weights. The main finding is, I mean, not entirely surprising, but good to quantify that during the COVID-19 pandemic, maternal depression symptoms increased. They're fairly stable, actually, 3-year, 5-year, and 8-year. And right at that first COVID-19 survey that we did, there's a pretty big increase. When we apply the weights, we see that doesn't change. That estimate, it's a little bit smaller, but the general trend is very similar. So all that to say, attrition can be an issue in these samples. We expect it, and we have some methods to deal with it, but that doesn't necessarily mean just because people are dropping out that it's always introducing bias when we have, depending on the exposure outcome relationship. So that's kind of our example. Okay, so I'll give it back to you.
Thanks, Tona. Yeah, we're really happy and I'm proud of this achievement with our attrition weights, and it really is balancing sort of later sample or data weights with our baseline characteristics, and it's different from weighting, say, like what StatsCan would do to the general population. Those aren't the survey weights we're using, and this is inverse probability treatment weights when it just balances to the original sample at baseline, and it's really cool to see how they are applied. So thanks for that, Tona. So in terms of data access, we have a couple of different ways that we share the data. So next slide, please. Oops. Oh, that's okay. Yeah, just back there. So we have 3 types of sharing agreements with different data users. So we have our trainees, we have internal data sharing processes, so that's U of C, and then we have external sharing processes, which is external to the University of Calgary. So in terms of the second bullet up there, we have an agreement just for our own tracking purposes, but we also have the data service level agreement, also known as a DSLA, and that's our internal U of C type of data sharing. And then we have a DTA, which is a data transfer agreement, which is with our external partners. And these forms differ a little bit in terms of signatories required, but not the access level received. So it's just the way we track things, the way we share things, and we're following university processes. And we are the custodian of the data, but these are just tracking processes and agreements that we have in place as we move forward. And both the DTA and the DLSA were created by Med Legal and Department for us, for the purposes of sharing data. So what we do require when data users are interested in sharing or wanting to use our data is we require a brief proposal, just a 2-pager. We do require ethics approval from the investigator. And of course, we have some signatures. And then in terms of data sharing, and Mary Canning is our data access and sharing expert, and I don't think she's on the call today, but one of the integral members of the team oversees this process. Well, we do the data sharing where you access the data via a spreadsheet. It's a bit clunky at times, so we are looking how to improve our data sharing processes and access process, but it's worked for us up to now, we have to say. So it's a big spreadsheet, as you can imagine, with all the data waves over time, picking your variables. It gets organized by wave, organized by construct, and then a data set is created. And it can be in various formats, from anything from a CSV file to a Stata file to Excel and SPSS or whatnot. So we have various formats, and all data is de-identified. So there's a scrambled unique identifier. We call it a study ID. We double scramble it, and then that's how we keep track and ensure that the data is de-identified and respecting the confidentiality and privacy processes in place from ethics. And we do have follow-up. So there's annual follow-up for the status of where the data is at and reporting. And we do repatriate new variables that have been created from investigators. And then we do ask that the data be destroyed or returned as per policies of U of C and different data sharing agreements. So why do we do this? Next slide. Well, is the process. So as I mentioned, MedLegal can be involved in the internal and the external sharing process, and this really is to comply with the university's data sharing policies. We do tracking. It's very important for us to do this. Who's using the data and what are the questions being asked so there's not duplication, and what disciplines. This is for reporting purposes and is very interesting to us to report on and for our funders as well. We monitor the outputs. Is the data being used for publication? How many presentations? So just that we're tracking this over time. And it's really important because this is reporting to our funders. We are required to report the data usage as per above. And this really does increase confidence, funders' confidence, and in their contributions to our study. So it's due diligence and it's a robust process we follow. And also simple accountability. Why are we collecting the data if we don't know how it's being used? So a lot goes into the reporting and the tracking and the sharing process. So these are important things. And next slide. In terms of the elements of data sharing, I sort of touched upon it a little bit. There's initial request. There's an online form that you fill out. There's also a data quiz that we have developed to really ensure that the user understands the eligibility, the response rate, the participant sample size, and that attrition are understood. And just recently, we've added some questions to help convey the data weighting and the attrition weighting that Tona talked about earlier to really understand why the weights were developed in the first place and how to use it appropriately. So we have a confidentiality agreement. We have a variable dictionary, which is that Excel spreadsheet I was talking about before. Of course, we require ethics from anyone who's wanting to use our data. We have these agreements, the 3 agreements I mentioned before. And then we also distribute authorship guidelines. So we really have accountability for who's using the data and how it's being reported. And we follow up, like I mentioned before. And so a lot of work goes into this, and each request takes up to 1 to 2 days a week of work, and it all adds up over time. So with that, I'll pass it back to Suzanne to talk a little bit about our outputs and bring us home. Over to you, Suzanne.
Thanks, Sheila. Thanks, Tona. So you're getting a little bit of an overview of a number of aspects of the platform, and I'm going to end the conversation today with how we've applied some of the research in knowledge exchange and made efforts at translating some of our academic learning to real life circumstances. So the technical outputs to date, which anybody on this phone that's part of the Academy knows we are accountable to our funders for and to our institution. So we've highlighted the publications, the number of grants. We are enthusiastic about making the resource available to trainees and have had a long-standing trainee program. We have mentored and collaborated with over 110 scientists, both locally and internationally. 57 data sharing agreements have been successfully executed, and a number of presentations as well. One of our upcoming opportunities that I think many on the call will be aware of is the interest in creating a data platform through the One Child Every Child program, combined with AwareCo and combined with CHI and other interested parties. So we're looking forward to being able to execute that as well. So we have sort of a value proposition in all our families that has guided some of our activities around communication. And those are really the abbreviation of the evidence to policy or evidence to practice gap. So our findings have informed position statements, Alberta Health Services policy and guidelines, and Sheila's played a unique and helpful role in making sure that the information, particularly in time-sensitive issues like COVID, are widely distributed and made available to decision makers. We have evidence-based commentary that respond to other clinical guidelines. We've engaged with the Public Health Agency of Canada, and we've really made an effort to share our findings with community organizations that are committed to meeting the needs of citizens, and particularly those who are vulnerable. So we had some surveys that went out to our participants, asking them what they would like from all our families. And we made a number of sort of standard checkbox questions, but we also had some text options. And one of the common themes that the participants, mostly women in our studies, said is, well, you know, what have we learned? We've been filling out these surveys for over a decade. And what's the big outcome? And it was an interesting learning experience because, as we've said through this program, this presentation, we have shared fast facts and findings from our research in our newsletters. So 25% of women experience mental health challenges within 3 years of delivering a newborn, or transitions in the back to work stage look like this. Children are uncomfortable and mothers are uncomfortable. And so we had sort of had an academic lens on sharing the information, but on further reflection, what it dawned on me is that women are also asking us, what do we do with this? Like, it's one thing to say we have these descriptive proportions of children with neurodevelopmental challenges or with limited access to recreation, or who are challenged at learning to read, or mothers who are returning to work in highly stressful organizations. But what it's like, so what? So I had the luxury and privilege of working with a bureaucrat for a number of years. And one of the things she really animated me about is academics are so enthused about admiring the problem, but you know, we got to get past admiring the problem if we're going to make change. So all that as an introduction to the development of a workbook called Cultivating Resilience and Flourishing. And to create this workbook, we looked at all of the data that we had published over the past decade and the broader literature to curate the qualities that families had that enabled them to be successful when you would have predicted that they would have tanked. So what are the things that families have implemented that make an awful outcome the very best it could be? And these were then framed in the construct of routines, resources, and relationships. And we have published this workbook and made it available initially to all of the women in our study. And I mean, I'm abbreviating the 2-year process to get to this because I'm, in the interest of time, I'd like to save time for questions. And so in producing this workbook for them and then sharing it with our community partners, it came to our attention that really there are a number of organizations that are interested in the same thing. And so we have now gone and taken this work a step further, and it's available now in not hardcover, but in print format. And then in our effort to make it 100% accessible, it's available at no cost online in color and black and white. For the uber fast, just get me to the brass tacks person, the worksheets and a preamble are available in a micro abbreviated form. And we've been now working with communities and participants in how to apply these guidelines in your activities of daily living, all based on the premise that if we can reduce the activation of our stress response system, we can enable then better decision making in difficult times. We were very committed to trying to make this accessible and have connected with the Connections First website through the Burns Memorial Fund, given their reach into the community. So the materials are hosted on their website. So the background to the workbook is the physiology of the 3 R's based on routines, resources, and relationships is kind of a repeat of what I've just said. But how do we enhance life satisfaction and enable resilience and flourishing for families who are living in contemporary society where there can be a number of challenges to your activities of daily living at any single time. And we make it very clear that we realize that life happens. So how do we then facilitate things? And with that, I would like to acknowledge all of the funders that have supported our work over time. And this is only really many of those identified here who have been the financial sponsors of the work, but without the connection to our community partners from the Boys and Girls Club, United Way, Calgary Sexual Health, the Girl Guides, the Scouts, everybody that has given us feedback and insight into what we really need to pay attention to help families and children. We also recognize them. And of course, the participants who have stayed with us now until maybe even will keep long enough until their kids are voting age. Who knows? So I think I'd like to end there unless there's any quick comments that Sheila or Tona would like to make, so we have a chance to answer your questions.
Yeah, that sounds great, Suzanne. And yeah, really giving back to our participants is what it's all about. And it really has been a long time. We're talking 2008. I can't really do the math. Tyler, you can do it quicker than I can. But anyways, it's been a long time coming, and we're continuing to now do our next data wave where the youth are 15 to 17 years old, and we can go on after that too. And could be embarking on an intergenerational cohort at one point. So yeah,
well, I do want to finish with one thing and a bit of a shout out to Sherry Madigan, who's not with us today, but she's taken a very large leadership role with the youth, because of course you can imagine as the cohort has evolved, different expertises become more and more important. So just a recognition that we've had lots of input from some great scientists.
Yeah. Any comments or questions? Seeing a few things in the chat.
We see fantastic work regarding the pre and postnatal blood samples collected. Do you have assessment outcomes covering effects of maternal exposure to substances, example mining analytes, on the child development? Also, how were the maternal depression symptoms measured? Were they self-reported? Good questions.
Yeah, I can jump in. So yeah, Dr. Donna Slater and Katie Chaput are our biocord leads who can maybe help with that. But yeah, we do have blood samples for sure twice during pregnancy. We did collect cord blood at birth, as I noted, but I do believe those samples are not valid to be used. But just going back to your question, sorry, I lost it in the chat. But yeah, there's those samples can be used and linked to survey data to answer important research questions. So I would say, contact Dr. Donna Slater and Katie Chaput for that. And in terms of maternal report, yes, it was self-reported depression. So we had those validated measures, the EPDS and the CESD over time. So self-report for depression symptoms. And then we have linked to administrative data to look at depression diagnosis as well to get diagnostic data, but we don't have diagnostic data from surveys.
Excellent answer. You answered mine quite nicely about data sharing and the process that you have. It sounds like a very streamlined way to go about it, and you're very thorough. There's a few more questions. Do you maintain a biobank of blood samples that can be requested for maternal exposure analyses?
Yes, we do. Yes, we do. And again, Donna and Katie would be the best to connect with, but we do have that data that can be shared and linked with survey data as well.
Okay.
And we're very enthusiastic to share it because Donna has been very clear that she doesn't think we should be storing these samples forever. So we are doing what we can to try to make sure we can analyze the samples and make them available.
Great. I think other people can also ask the questions, but I'll read another one here. What is the number one piece of evidence that's come from your All Our Family study that you've been most proud of? That came from Tyler. They're thinking.
I mean,
Suzanne,
Well, I'll start this off, and I'd love
Yeah,
to hear
sure.
Sheila and Tona's comment too. But I think when I reflect on the body of work, and when I started, over, 17 years now, as Tyler's pointed out, the idea of understanding the intersection between women's mental health and family well-being might have been considered either impossible to describe or not really very medicine-y or not very traditional. And I would say that over the years, one of the things I've felt satisfied about is the deeper appreciation for the importance of supporting families during the childbearing years, and recognizing that there are so many things in our community that elevate family life more than I think we give them credit for. So a concrete example would be working with our community-based organizations and demonstrating that having a library card is hugely protective for children, even if mom is depressed, is important for the public library system to know. They've gone from paid library cards to free library cards. Now, our evidence hasn't been the only thing that's influenced them, but also it alleviates the suffering that women feel, or the guilt that women feel when they don't feel and when they know they're not on top of their game. So I think one of the things I'm happy about is the exposure of how we can support families and mothers, and that we all have difficult stages over time.
Yeah, I would add to that. It's sort of the normalizing those experiences that families are going through and having that data to back it up. We can talk about the literature or whatnot, but this is local data that we can show that how families are doing or experiencing, and normalizing some of those, especially mental health symptomatology, and then what to do with it. And so the importance of connections and social support has really stood out over time in all our families. And Tyler, I'm chuckling a bit because I would say I'm very proud of anything methodological that goes on with this cohort. I mean, the attrition work is an example of that. But we do our own psychometric properties of the scales we use, and we compare it to those in the literature, or we're looking at different ways of, analyses and all the complex methodology, longitudinal analyses over time, and just really staying on top of our game from that perspective as well with this cohort. So I would say both the content and methodology I've been the most proud of in my time as a scientist and now co-PI of the cohort. And Tona, anything to add from your perspective?
No, just that one of the cool things about when you create a community like All Our Families with engaged scientists as well is that you have this ability to respond very quickly to like disaster. So the COVID response, having 3 surveys over that time period and continuing to follow up is really important. It's something that AOF is in a unique position to do. So you don't have to go out and recruit people, and you already have this existing cohort you can kind of build on during that time. So a lot of insight during the COVID time period in particular, but also the floods in 2013 being very responsive to that, and just ongoing natural disasters too. We talked about the eco-anxiety, and then the wildfire smoke exposures that are going on consistently now in Calgary as well.
I'm just going to finish on that because another, although Tyler asked the word about evidence, but another component of the program that I feel really privileged to be part of is the authentic connection to community in informing us and in helping us guide our research to answer questions that they need to know the answers to meet the needs of the people that they're trying to serve. And so we've sat on numerous committees and numerous opportunities to really know how those organizations work and contribute. And I think that has really gotten me out of my office for sure in new ways. Met some wonderful people.
And just before before we wrap up, there is one more question. We can take it as the last one. Do you have maternal and early childhood vaccination data as part of this project when you collected pre and postnatal data linked to labor and delivery records? Are these also race-based segregated?
I can offer the first part. Dr. Shannon McDonald at the University of Alberta is our vaccine expert, and she has published on vaccine and vaccine hesitancy using all our families' data. Now, the last part of the question, whether it's race-based or not, we have ethnicity in the cohort. I'd have to go back to see whether or not that was one of the core variables that we were looking at when we did that analysis. And certainly we have all the other descriptive demographics, so employment history and income and number of years in Canada and language spoken at home. But Shannon's work really revealed that vaccine hesitancy in Alberta at that time, and this would have been pre-COVID, I think, Sheila, right? Pre-COVID, was more due to logistical barriers than it was to any resistance per se writ large of vaccines. So families moving with young children, not knowing where the community health center was, children being sick when the vaccine would have been suggested, and then having to figure out how to get back in the vaccine cycle. But that's all available on our website for those that are interested.
Yeah, I would agree. We've done quite a few studies around that, and so we collected both qualitative data and quantitative data on that. So we were able to look at the reasons for hesitancy, like Suzanne was mentioning. But we also link to the public health database in Alberta to actually get the vaccination status. So the linkage piece, for the cohort has been invaluable to answer these important questions.
All right.
Yeah, thanks, Sheila. Thanks.
And thank you to our three speakers today, Suzanne, Sheila, and Tona. We're very proud to have this work being done at U of C and ACRI. And ideally, we would like to be able to sort of advertise for your cohort on the CHI website. So we'll be contacting you to just get a few more of those specifics and post it, and hopefully more people can add to your body of research. So thank you again. Wonderful. Thanks all for attending. Bye-bye now.
Bye-bye.
Thanks.